Hello? Okay. Oh. Hello. Good evening, ladies and gentlemen. I'm honored today to have our guest speaker for this evening, Professor uh, Zolt Molnar. He's a full professor and head department of anesthesia and intensive therapy, University of Szeged in Hungary. Professor Zolt is fond of undergraduate and postgraduate teaching. He is a medical director and in European Berlin, Germany as well. He has published several, he was involved in several clinical researches projects, mainly in critically ill patients, including inflammatory marker research. And he and his group have several publications on lung recruitment in ARDS as well as sepsis. He published around 98 manuscripts, and today he will talk to us about the interpretation of procalcitonin at bedside and the clinical utility of procalcitonin in patients with COVID-19. Welcome, Dr. Molnar.
Hello, welcome everyone, and let me share my screen. And thank you very much for the nice and very kind introduction. And also I would like to thank the organizers and Roche for inviting me to deliver a lecture on the interpretation of procalcitonin at the bedside and its clinical utility, especially in COVID-19 patients. So yes, I am a professor in anesthesiology and intensive therapy. I've been practicing for 30 years now, and I had been a medical head of department at the University of Pécs, but now I am involved with the translational medicine department at the University of Pécs in Hungary. So I'm doing research and teaching, and I also have two other clinical affiliations in Poland and in Hungary. And I am also a medical director at Cytosorbents Europe. So much about my disclosures. And before we speak strictly about procalcitonin, let me take you into the domain of pathophysiology, and let me take you back into the early 1990s and 1930s and introduce to you this gentleman who you possibly heard of. He is János, or Hans Scheer. He was born in Hungary and then performed most of his research in Montreal, Canada. And this is a paper he published in 1936 in Nature. And it summarizes the results of his experiments performed on these rats. And what he did was that he exposed the rats to acute non-specific injuries, cold, surgical, spinal shock, whatever. And then he observed the response. And what he found, that this typical syndrome appeared in the animals, which was independent of the nature of the damaging agent of the injury, but it was a response to the damage. Possibly you know what he was talking about at that time. This was the discovery of stress. Apparently he was nominated for a Nobel Prize, but he didn't get it. And then he was nominated for 16 more times for a Nobel Prize, but never received it. Anyway, his discovery of the host response to an injury lingers on, and we've been following in his footsteps. And we can use this knowledge now, and we can translate this into the domain of inflammation. Fundamentally, there are two types of injuries that we can suffer. One is physical damage, when there is direct cellular damage after trauma, surgery, ischemia, reperfusion, whatever, when the cellular structure itself receives the injury, the damage. And the other one is a pathogen-associated injury caused by bacteria, virus, and fungi, so a pathogen. Now, the striking discovery was that regardless of the nature of the injury, whether it is damage or pathogen, the associated molecular patterns are more or less the same. So the same molecules, mediators are released as a result of the injury, regardless really, more or less, whether it was damage or pathogen. Now, we do suffer these types of injuries during our regular everyday life. Just imagine how the face of this boxer will look like tomorrow and what will happen to this freshly operated knee the following day. Both will show the signs of local inflammation. It will be swollen, tender, warm, red. So indeed, showing all the signs of local inflammation. But this gentleman here and this woman will recover after a few days. He will go back into the ring to practice boxing, and this woman will leave hospital if everything goes well. And we do suffer pathogen-associated insults. Local infections like this ugly incarnated toenail. When the inflammation is going on, you can see that. It's swollen, it's red. I'm sure it's painful and hot. And we do suffer sometimes a generalized infection like a flu. This is very actual nowadays, of course. When we are in bed, aches and pains all over, high temperature, we are feeling awful. But this toe can be repaired without any medical help, and we can recover from a flu within a few days if we are healthy. So in other words, we can suffer injuries, but if we are healthy and the host response is normal, our response to this injury is normal, then we can recover without any medical help. So it is important to know that procalcitonin, which is an inflammatory mediator or marker, can be induced by both pathogen and damage-associated injuries. And this was a major problem when people dealt with procalcitonin as a sepsis marker. It is not a sepsis marker, but we will get back to this later on. So the message here that both DAMPs and PAMPs can cause elevated inflammatory mediator levels, including procalcitonin. But going back to the cytokine story, cytokines are needed and inflammatory mediators are needed to conquer these injuries. But it is only beneficial if we are in balance, we are healthy. And health to me means that we are in balance as depicted by this yin-yang. And this depicts the balance between the antagonistic forces in our body. Now, possibly there aren't that many critical care physicians in the audience, but nobody understands this better than we critical care physicians, that it is vital for our body to function properly. Just think about homeostasis. It is a balance between acid and base, two antagonistic forces, but they must be in balance in order for our pH to be on, our hydrogen ion concentration to be on 40 nanomole per liter, to provide the physiological pH, then for our enzymes to work, to stay alive. If this goes into imbalance, then the patient will end up on a dialysis machine and on the intensive care unit. The same is true for hemostasis. It is a balance between pro and anticoagulation. It's a dynamic balance which protects us from developing deep vein thrombosis and emboli, but it can stop the bleeding if you cut your finger. Two antagonistic forces acting in balance. Oxidants, antioxidants. It doesn't make any sense to take antioxidants if you are healthy, because this is again a fine-tuned balance. But we need both forces, but they must be in balance, just like, and this is the most important topic today, is the balance between pro and anti-inflammation. This is a very nice article written by my good friend Didier Payen and co-workers. And in this paper, you can find this figure. What it tells us is the following. Our immune system has two components, the innate and the adaptive. Let's call the innate the pro-inflammatory force and the adaptive the anti-inflammatory force. Now, when we are healthy, free of any injuries, then our immune system functions on a baseline activity, baseline level, and protects us from the environment. The skin is the number one protection, but via our orifices, we are open to the environment to some extent. So when we inhale anything, then it's in the lung, the immune system deals with it and would not allow to enter our circulation body. What happens when we when we suffer an injury, let it be damp or PAMP? Then our immune system, as nicely depicted on this figure, changes gear, increases its activity. But both the innate and the adaptive increases its activity in a parallel fashion. The role of pro-inflammation is to kill the invading pathogens and to get rid of the dead tissue after trauma. The role of anti-inflammation is to keep this work under control. And if they function in harmony, then we can recover within a week or so without any medical help. The problem comes here that the critically ill patients, this nicely controlled balance goes out of control and pro-inflammation can overwhelm anti-inflammation, and these patients can die early due to fulminant septic shock, for example, or due to fulminant dysregulated host response. And this is a key issue in now the new sepsis definition, because now we realize that the systemic inflammatory response syndrome, the SIRS, was a wrong concept. It labeled normal and essential responses as pathologic. But now if you read the new sepsis septic shock definition, this is the first author, my good friend Mervyn Zinger, then it states clearly that sepsis now is, it means for us a life-threatening organ dysfunction caused by dysregulated host response. And this is the key in this story. Now, we know what sepsis is, and this is a question I receive very often from my junior doctors on the ward rounds. Is this patient septic or not? Now, this is something I am not interested in at all, because it wouldn't change the course of my treatment, or wouldn't change the outcome of the patient, just knowing whether the patient is septic or not. If I really want to be provocative, I quote that I have never ever treated sepsis in my entire life. But I treated patients like this one, hundreds of possibly thousands of times. And we discovered that the patient is in respiratory failure, so we dealt with it. We discovered hemodynamic instability, we gave fluid, vasopressors, positive inotropic agents, and so on, and we dealt with it. Renal dysfunction can be dealt with pharmacological therapy, dialysis, altered mentation possibly requires intubation, mechanical ventilation, put the patient off to sleep. And we can give several life-saving medications, artificial feeding, and so on. So in other words, we don't treat sepsis, but we treat organ dysfunction via objective physiological parameters. And within the domain of sepsis, we treat infection, if there is infection. Why is it important to make this decision? Because if the patient has infection, and this is the reason of him or her being critically ill, then we should give antibiotics. In fact, as suggested by this highly quoted paper by Anand Kumar and co-workers, you should really give it as soon as possible, but the current sepsis guideline says within 1 hour. However, if there is no infection, then we shouldn't give antibiotics, because antibiotics are harmful drugs. This is, again, a very provocative, excellent paper written by Mervyn Zinger. I don't want to get into this controversy of giving or not antibiotics, but we will now move closely, we're slowly moving towards procalcitonin, how procalcitonin can help us in this. And why we need some help, because roughly 28% of the patients who receive empirical antibiotic therapy, it is inadequate. But we need to start empirical antibiotics, at least we believe so, and guidelines recommend to start antibiotics early. But we have to bear in mind that 25 to 30% of cases we start wrong antibiotics. And if we start wrong antibiotics or inadequate antibiotics, we may do harm. And one of the biggest problems in hospitalized patients is antibiotic resistance. you can see that the more antibiotics a country uses, the higher, for example, the penicillin-resistant strep pneumoniae in that particular country. So the conclusion of this, that antibiotics are overused and abused worldwide, and multi-drug resistant pathogens, several authors regard this as a global crisis. So this is why it is very important to be as certain as possible whether critically ill patients have infection or not. We have no time to delay sometimes antibiotics. So the clinical signs are very important, but we all know that these are just not good enough. The traditional laboratory values like leukocytosis or leukopenia or fever, these are very good possibly at home, but they can't tell you whether it is bacterial or viral infection. In fact, regarding the critically ill patients, and this is an early paper and this is ours, I will quote this later on during my talk, this is in fact a very poor indicator of bacterial infection, and the sensitivity hovers around 50%, meaning that it is not any better than if you toss a coin. If it is head, the patient has infection. If it is tail, the patient doesn't have infection. Very non-specific and non-sensitive indicators are these of bacterial infection. Obviously, microbiology is extremely important, but we received the results quite late, sometimes a couple of days, and several times it is false positive or false negative. So it is, again, something that comes late. So we need something else. And this is why we use biomarkers. Unfortunately, as I have already pointed out, these are often referred to like sepsis biomarkers. I disagree with this because these should be called inflammatory. And let me just remind you for my DAMP and PAMP slide that both can cause inflammatory response. It's not bacteria specific. Undoubtedly, I've been using procalcitonin ever since it was released, 1998, and I gained a lot of experience with it. And we learned something every year about procalcitonin, and we developed kind of a special approach. And towards the end of my lecture, I will share with you this results. My first warning is that using biomarkers is not easy, and this is something we learned over the last almost 30 years, or exactly 30 years, or 20 odd years anyway. So what about COVID-19? Why do we potentially need, or what is the use of procalcitonin? Why do we need to diagnose infection in COVID-19? So this is one of the early reports from China. And you can see the trajectory for survivors and non-survivors. And the symptoms are more or less the same. There is only one major difference here, this red these red boxes, which indicate invasive ventilation. And with invasive ventilation, secondary infections can occur, and death is usually the result of this, while survivors who do not get secondary infections and mechanical ventilation, they usually survive and can be discharged. So on the one hand, we need to identify co-infection on top of COVID-19. Furthermore, there is a syndrome which is called hyperinflammation or cytokine release syndrome. And this is data from the German registry of hemophagocytic lymphohistiocytosis in adults. And in these patient population, cytokine release syndrome, cytokine storm, hyperinflammation is indeed a major issue. And you can see that infections are responsible for cytokine release syndrome in almost 50% of cases, of which viral infection is the biggest single domain. Nearly 30% of patients present with some kind of hyperinflammation. So the second aim of using biomarkers to detect this dysregulated inflammatory response or cytokine storm. What do we know about procalcitonin in viral pneumonia? Obviously, we have more data than in COVID-19 patients. Well, there have been a lot of studies published on this topic, so I will just give you a small cohort, a small bundle of these, just to show you where we are. So this is a nice study published a few years ago, and they tested procalcitonin concentration in patients admitted with viral, atypical bacterial, typical bacterial, fungal, and unknown origin of pneumonia, community-acquired pneumonia. And you can see that statistically there is strong difference between the PCT levels in patients who had proven viral as compared to the proven typical bacterial pneumonia cases. And indeed, when you look at the receiver operating characteristic curve to predict viral or bacterial pneumonia, the higher the PCT, the higher the likelihood that the patient has bacterial. On the contrary, the lower the PCT, the higher the likelihood that the patient has a viral cause of the pneumonia. Now, when you look at this, indeed, it is statistically significant. But when you look at the individual data, these patients here with proven viral infections had higher procalcitonin value than patients belonging to the lower quadrant and cohort of those who had typical bacterial. So although there is a statistical significance, but measuring just one single PCT level, it will not help you. And the authors conclude that no procalcitonin threshold perfectly discriminated, but indeed there is a tendency that higher PCT strongly correlated with increased probability of bacterial pathogens. So there is a tendency, but you cannot use it at the bedside. Some authors suggest threshold and cutoff values, like these authors in this Lancet paper. They suggest that if it is very low, the PCT is very low, or if it is higher than 0.5 nanogram per milliliter, then this indicates viral cause or suggests viral cause. This suggests bacterial cause. But even the authors quote that no clinical algorithms exist to discern clearly the cause of pneumonia, because although there is a tendency, but it's very difficult to give thresholds. In this study, there is again clear distinction between viral only and bacterial co-infection with viral pneumonia, and they also calculated the best cutoff value, which was 0.8 nanogram per milliliter. But again, the authors concluded, on the one hand, that it's obviously not an area on the curve, on the ROC curve is 100%. But when they combined low PCT below this best cutoff value with the absence of alveolar consolidation, the odds ratio increased up to 13 for no co-infection. So it is an important paper from the aspect that you have to merge your biochemical data and the clinical picture of the patient. What do we know about procalcitonin in COVID-19 cases? This meta-analysis and pooled result shows that there is some link between severity and procalcitonin. 4 studies were pooled in this meta-analysis, and they found that elevated, usually this is the cutoff we use in critical care, 0.5. So elevated PCT was associated with a 5-fold higher increase risk for a patient to develop severe COVID-19 infection or critically ill condition. So it can be a useful tool in the accident and emergency department to kind of pinpoint those patients who may have higher risk for developing severe condition later on. This is also a study coming from China. 1,000 patient data was evaluated. And these are patients with low severity or patients who did not have adverse outcome. And interestingly, these patients had positive chest radiography and chest CT in very high numbers. More than 50% had positive, so abnormalities on the chest X-ray, and more than 80%, regardless of the positive outcome, more than 80% of these patients had radiological abnormalities on the chest CT. And again, CRP is just as bad as chest radiograph and chest CT. It was elevated in these patients. However, PCT, there was a distinction. PCT didn't jump. So these could be regarded, regarding the severity and outcome, as false positive results. So PCT may help to identify patients who are, again, at low risk for severity of disease and adverse outcomes. Not a big study, but it is interesting. They kind of looked at procalcitonin ranges and levels, and looked at ICU care, or compared those who were admitted to ICU to those who were not admitted to ICU. And those patients who didn't have to go to the ICU, they had very low PCT, about 80% of these patients, and the results were significant. And those patients who had higher than 0.5 nanogram per milliliter PCT level, then 25% of them were treated on the ICU, and nobody had high PCT level of those patients who were not admitted to the ICU. So the general feature of COVID-19 seems that on admission, the PCT, fortunately, is low, and we know that most patients have uneventful course of the disease. None with a PCT of less than 0.5 needed ICU admission, and 3 out of 4 patients who developed bacterial infection, then the PCT jumped over the 0.5 threshold. So this is something where if you suspect infection in an already admitted ICU patient in whom you did not start antibiotics, and there is a jump in PCT, you may have some more justification for starting antibiotics. Unfortunately, this is not the practice. If you look at this cohort, again from China, 100 patients, then they measured PCT, interleukin-6, and C-reactive protein. I'm just focusing on those. Only 6% of patients had increased PCT levels, 50% had elevated interleukin-6, and 86% had elevated C-reactive protein. And only 1 patient had proven bacterial co-infection. However, 70% of the patients received antibiotics. And there was only, as you see here, only 1 patient with bacterial infection. Only 4% of patients required invasive mechanical ventilation, and only 23% needed ICU admission. Unfortunately, we have no subgroup data on PCT on this. So I have doubts regarding antibiotics. In fact, I am absolutely certain that this high rate of antibiotic administration is totally unnecessary. Now, I have been talking about inflammation and hyperinflammation, and recent data has been published, which is a bit, it is at least questioning whether COVID-19 and hyperinflammation is typical. This is a study from Peter Picker's group from Nijmegen, the Netherlands, and it is an excellent research group, and they compared COVID-19 patients with ARDS, obviously on ICU, with previously published important papers on sepsis with ARDS, sepsis with no ARDS, out-of-hospital cardiac arrest and trauma. And in general, what you can see here, that there is significantly higher TNF, IL-6, IL-8 concentration in the sepsis cohort with ARDS, and it is not as prominent with the COVID-19 patients. And I entirely agree with Peter Picker's conclusion that the finding of this preliminary analysis suggests that COVID-19 may not be characterized by cytokine storms or hyperinflammation. However, it is important, in my view, to acknowledge that COVID-19, even with ARDS, of course, doesn't mean hyperinflammation. Hyperinflammation is a complex thing, and usually it is accompanied by vasoplagia, so severe hypotension, shock, and other features. And in a subgroup of patients, indeed there is a hyperinflammation if you just look at the upper quadrant of this population. And this population may be detected by measuring IL-6, measuring procalcitonin, and others. The story went on, and this is the most recent publication on this story, the cytokine story by from the UK and published in the Lancet just very recently, a couple of weeks ago. And they did something very similar, but on a larger scale, comparing severe COVID-19 to other conditions. And just one thing to show that the COVID-19 patients had very low or no PCT levels as compared to the septic patients, where PCT was already present on admission. So hyperinflammation is not a common feature in hospitalized COVID-19 patients, but this is something very good, because this is why we can use procalcitonin as a ruling out marker. And so how to use procalcitonin in addition to ruling out, but to guide our antibiotic therapy in general. The current Surviving Sepsis Campaign guideline released a COVID-19 guideline earlier this year. And what they suggest is to add empirical antimicrobials over no antimicrobials to mechanically ventilated patients with COVID-19. However, it is weak recommendation and low quality of evidence. And looking at if you remember for my previous slides, the very high number of patients who are treated empirically with COVID-19 with antibiotics, the very high rate of multi-resistant strains and multi-drug resistant bacteria in hospitalized patients, it is an alarming signal, and possibly this is not the best advice we should follow. And this is going to be 2 papers now from my previous study group. And this is Domonkos, the first author, and my former PhD student, who was the first author of the 2 papers. So on the one hand, we measured procalcitonin in more than 200 patients in whom on the ICU we suspected infection. And patients were recruited, these 200 patients, on the day when we suspected infection. And in a post-hoc analysis, we found that in 114 patients, we had procalcitonin from the day before. So we were able to evaluate a 24-hour change in procalcitonin before the day when we suspected infections to the day when we suspected infection. Now, 2 infectologists in a post-hoc manner identified patients with proven infection compared to those who did not have infection proven. And you can see here the dashed bar indicates patients in whom there was no proven infection, and PCT was low and remained low. But patients who had proven infection, the day before there was no change between the 2 groups, but then there was a significant increase both from day 1 and both as compared to those without infection. So we also calculated the area under curve, and we of course evaluated C-reactive protein, white cell count, and temperature, which worked out a 50% area under curve, no better than tossing a coin, as I said earlier. And there was an 85% area under curve for elevated PCT. So if you measure procalcitonin daily in your hospitalized, and especially in the patients admitted to the ICU, you measure PCT daily, you may detect this jump in PCT, which can give you a strong alarming signal. And if you suspect infection, you have an 85% chance, or roughly something like this, to make the right decision to start empirical antibiotics. The main question of the study, we call this the EPROC study. EPROC stands for Early Procalcitonin Kinetics and Appropriateness of Empirical Antibiotic Therapy in Critically Ill Patients, was how procalcitonin kinetics can help us to give us a hint whether the patient is receiving appropriate antibiotics or inappropriate, because the microbiology and the susceptibility test will come, and the resistancy test will come in a day or 2 or 3 sometimes. So let's see. What we did, we measured baseline PCT value when we commenced antibiotics, and then we measured PCT in the study 8 hourly within the first 24 hours, and then daily. And again, in a post hoc manner, two infectologists decided how many patients received appropriate and how many received inappropriate antibiotics. And you can see that there is an obvious difference between those in the PCT kinetics between those who received inappropriate antibiotics as compared to those who received appropriate antibiotics. Patients in the inappropriate group, in these patients, the PCT kept going up for 24 hours and then plateaued, whilst those patients who received appropriate antibiotics, the PCT reached its peak somewhere here, 12 to 16 hours, and by 24 it was already coming down. We also calculated the area under curve, and if you measure the 24-hour change, a more or less than 70% increase in PCT can give you some kind of a similar area under curve like before, an 80% chance to decide whether or not your patient is receiving appropriate or inappropriate antibiotics. But most importantly, this study helped us to develop a strategy that we evaluate the procalcitonin kinetics rather than using absolute values. So PCT, or to be honest, if whatever biomarker you use, I would strongly suggest to look at the kinetics, but PCT has an ideal kinetics because of its half-life, that is 24 hours. So you can see that the changes within 12 hours, 24 hours nicely. And if you use this kind of approach that you evaluate the change in PCT, like published and presented in this study, again in Lancet Infectious Diseases by a Dutch group, what they did was that in the PCT-guided group, they stopped antibiotic therapy, regardless of the length of antibiotic therapy, if the procalcitonin dropped by 90% as compared to the peak value. And what they found was, and in the standard care group, they just followed simply the guidelines. And it resulted in almost 2 days a reduction in antibiotics. There was reduced mortality and also reduced costs. There were more reinfections, but it did not reflect in either in the costs or mortality. So the message of this that kinetics may help individualizing antibiotic therapy, and this holds true for any patient, including COVID-19. This is a very recent paper and a very nice one, and I have no time to go in depth, but in this paper, by Philip Schütz and co-workers, and this was a consensus paper, a European consensus paper, they provide 3 nice tables which is easy to follow and gives a more or less feasible approach how to deal with how to implement procalcitonin in your daily practice, more or less using a similar approach that I have been explaining in the previous slides. Now, we have some data now in COVID-19 patients, and this study evaluated the change in procalcitonin during the course of these patients' COVID-19 patients, and they measured the day before and the day after PCT, so something similar what we did in the EPROC study. And in general, they compared patients with confirmed infections to those in whom infection was not proven. Now, the numbers are very small, but at least there is a tendency that PCT was decreased, and it was more pronounced in those with confirmed infection as compared to those without infection. It did not reach statistical significance, but at least it shows the signal, and possibly it's down and it's to the small numbers that they couldn't find statistical significant difference. But in this study, there was a significant difference when they used procalcitonin guided approach, and again a 2-day reduction in antibiotic usage, and it was 5 days as a mean in the PCT guided group, and those patients who had high PCT antibiotics were carried on for 7 days. So the difference was significant. So in summary, I think that monitoring PCT in critically ill COVID-19 patients, it should be a routine. At least I don't think CRP is any better. In fact, I didn't have any slide on this, but I'm happy to answer any questions. Why I would not use CRP to monitor the patient's progress on the ICU. Low PCT can be a helpful tool during the triage process and also to early identify patients with low likelihood of bacterial infections. Evaluating PCT kinetics and especially increasing PCT can help identifying superinfection, and PCT kinetics can help targeting and individualizing antibiotic treatment. So with this, I would like to thank you for your attention. And of course, I am happy to answer any questions.
Okay, thank you very much, Professor Zolt. It was really excellent talk, and thank you for sharing with us your experience in this field, procalcitonin and other biomarkers. We'll just see if we have questions from the audience. Maha, I can't see anything in the chat. So until I receive a question from the audience, just a quick comment, and I'd like your feedback as well. As you said, following the kinetic of procalcitonin, it helps to identify patients, critically ill patients, especially in ICU, who are not doing well on certain antibiotic, which could mean that the antibiotics is not appropriate, but at the same time we have to make sure that the source is controlled as well, because as you may know that many patients who are critically ill, sometimes they are not able to go to surgery, for example, to drain an abscess, abdominal abscess, etc. So would you like to comment on this?
A very good question indeed, because the question, whenever we suspect infection, is the algorithm of the way we approach the problem is the following. If there is a signal which makes the bedside physicians suspect infection, then I have the following questions. Number one, where is the source? If you cannot identify the source, then and you are uncertain, then it is a problem. If you identify the source, then have you done everything to eliminate, eradicate the source? This means, have you started empirical antibiotics, or have you done surgical drainage or removal of the abscess or the infection? Or in other words, is the source under control? And if the source is not under control, forget about antibiotics, surgical control, then again, there's no point starting antibiotics. You have to do first the removal of the source. For example, very often the patient shows the signs of infection, high temperature, PCT jumps up, but then we figure out that there is a central line in the patient for 10 days. So then the next thing is to remove the central line. And very often, if there is no other source, ventilation is fine, the patient is hemodynamically stable, so there is a signal that the patient could have developed infection, but there is no other source. Let's change the central line. And very often the problem solves itself and there is no need for antibiotics. So source control is vital. And there is also data that if you don't do your source control, in fact, the time between the onset of septic shock or infection and to the time of the source control is more important, according to a large multinational study, than simply starting antibiotics. So it is of utmost importance.
Okay, thank you very much. So there are a few questions in regard to the CRP. I think you answered that, but let's re-emphasize. Someone is asking why would not use CRP instead of PCT in patients in ICU?
Yes, the C-reactive protein has a half-life of something like 30 to 48 hours. And every study, and I did not show you our data, but there are several studies indicating that the response is extremely slow. After the onset of an insult, like after major surgery, PCT keeps going up for 2 days, even during an uncomplicated post-operative course, and then starts its decline. Onset of septic shock. Regardless of the therapy you do, PCT keeps creeping up in pancreatitis, in any type of sepsis for 2 days. And on the other hand, it is elevated in almost every critically ill patient. So it is elevated, it's high, and it has a slow response. I cannot wait for 2 days to assess whether or not my patient is improving. We do ward rounds on the ICU at least twice a day, so in every 12 hours. And this is not by chance. It is not because we are workaholic. It's because a few hours, a few minutes can be avoid overlooking important issues. We have to evaluate the situation 12-hourly. And I would love to have a biomarker which follows the patient's progress nicely and give me reassurance that in addition of the obvious clinical signs, like gas exchange, acid-base balance, the requirement for inotropic support, the inflammation is under control as well. PCT is not ideal in this regard, but at least it gives us a strong signal even within 12 hours. So very often we measure it in the morning, but then if we are in doubt, we measure it in the evening as well, because that 12 hours can at least give us a signal whether the PCT is going up, remaining stable, or coming down. And of course, this is useful when we are in doubt, when we are not absolutely certain that, oh, this patient is improving. Then I have no questions. I don't care about procalcitonin if everything is improving, vasopressors are coming down, oxygenation improving, so we are going into the right direction. But when there is no improvement in 12 hours, despite all our efforts, then it is very comforting to have a biomarker that tells us what is happening on the inflammatory level.
Yeah. So it has also a prognostic, value. Like you know that the patient is doing well, the outcome will be better or it's getting worse. Another question here in regard to the doing daily PCT in ICU patients. You mentioned that.
Yes.
So you recommend to do PCT.
Yes.
In ICU patient on daily basis.
I think it can be cost effective. So, but to be honest, my colleagues, so it's a paradigm shift in the way of approach, in the way of thinking, and even my head ICU physicians did things like the patient was perfectly well, the PCT was coming down nicely, but they dared to stop antibiotics on day 5, and because well, you know, it's not 0.001 yet, so although it decreased by 80-90% as compared to the peak value, so and then it doesn't make sense to measure PCT if you do not use the information it delivers. So I mean, it's a paradigm shift, but if you use it the way we recommend it to use, that if it is low, if you just suspect infection, the patient is hemodynamically stable, please wait. Don't start antibiotics immediately. Withhold antibiotics. The patient is in ICU. You can change your decision in any minute. And if there is any other signal that creeps in, or you control the PCT and then it jumps up, there is still time to start antibiotics. If the patient is on massive hemodynamic support, then there is no time to wait. I agree. But then again, it's good to measure PCT because then you have a baseline value, and then evaluating the kinetics, the trajectory of PCT can reveal a nice evolution of the patient's host response. And do not forget that these are costly tests, so you cannot measure IL-6, tumor necrosis factor alpha, IL-8, so you cannot really evaluate the full picture in detailed laboratory measurements because it is so expensive. So whatever you use, there are several biomarkers. I do recommend to measure them regularly and evaluate the kinetics.
Okay. Would you like to mention a few causes of false positive PCT?
Yes, it is again a very important issue, and this has caused a lot of skepticism over the decades because physicians learned that patients after surgery had a PCT of 20 plus or even higher. But this was just a normal response for the insult of surgery. And the bigger the surgery, the more likely that our patients can have high procalcitonin. But this is not a problem. This is why we don't look at the absolute value, but then we measure it the following day. And if the patient's clinical picture is stable, then I would not continue antibiotics or start antibiotics just because the PCT is high. You have to put it in a context. It is a complicated thing, no doubt. And I warned you that using biomarkers is not easy. So damage, trauma, tissue injury can also induce immune response, and it can also induce elevated PCT. And there are, of course, papers which indicate strong, significant difference between patients with damp and with infection or sepsis or whatever, but you cannot really use them by the patient's bedside when you just measure one single biomarker level in these patients, because it can be false positive several times. For example, in viral infections, usually, indeed, in general, don't cause PCT elevation. But if there is a huge difference, if the patient comes to the ICU with a bit of hypoxia and requires non-invasive ventilation, but otherwise stable, and the same patient or a similar patient with the same flu infection comes to the ICU who is already on vasopressors because he or she has developed vasoplagia, the patient is in lactic acidosis, for example, this patient will have a much higher procalcitonin, although it is the same domain and the same virus, and possibly there is no bacterial co-infection. But the picture is affected by the damp component of the pathogen-associated injury. And this can cause, again, false positive increase in PCT. And we shouldn't forget that our own immune response it is really individually dependent, and we do not respond to the insults in the same manner. And this is why biomarkers, in any study you mention, they show a huge scatter. And this is individual variation between patients.
Yes, correct. I like really what you said during your lecture, that despite that ours makes a difference in critically ill patient. So if you need to start empiric antibiotic, you go ahead and do that. But always remember that giving it inappropriately might cause further harm to the patient. So as you said, the PCT alone is not will not give the physician an idea whether there is infection or not. We have to take it all in the context of the clinical picture of the patient, radiological picture, for example, etc. Do you see also high procalcitonin with patients on hemodialysis? I think this is one of the false positive causes.
Yes, indeed. Any extracorporeal circulation can induce inflammatory response, but it's not really the dialysis which causes elevated PCT, but the renal failure itself because of the clearance of the molecule. So it's been reported that in patients with acute renal failure requiring dialysis, it is usually a secondary renal failure. And the cause which caused renal failure also can cause PCT induction and PCT increase. And so, again, in general, procalcitonin can be higher in those patients with the same disease, in those who also require renal replacement therapy.
Okay. There are no other questions in the chat, but would you like to give us just a conclusion or home a message? I mean, for the audience that they should come up, go home with this message.
Yes, well, it's basically, and I think, that procalcitonin is a very useful tool. Let me tell you that I was a procalcitonin skeptic, and I simply wanted to do research with procalcitonin more than 20 years ago. And then it has become such a standard on both ICUs I was head of at the University of Pécs and the University of Szeged that none of my former colleagues would go back to the era of without procalcitonin or replace it with C-reactive protein and leukocyte count and so on. So it is an extremely useful marker. You have to learn how to use it. And the best way to do it is to measure it daily and evaluate the change. And trust me that if you are brave enough not to start antibiotics in hemodynamically stable patients with low PCT and no obvious presence of infection, then you will reduce your antibiotic usage big time. And if you are brave enough to stop your antibiotics when the patient's clinical course has improved and the procalcitonin has dropped by something like 90%, and this holds true in COVID-19 patients as well, then you stop antibiotics, then again, you will reduce your antibiotic usage. And one more thing, that on diagnosing infection, if you use daily measurements and you see a sudden unexplained increase in procalcitonin, at least you have a chance to look around and to find if there is no source of infection that you suspect, patient is stable, you don't start antibiotics. But if you look around and you figure out that, we haven't changed the central line for 10 days, it may help again the patient.
Yeah, exactly. And being an infectious disease physician, I would like, despite you said that the sensitivity or the yield of microbiology is low, but we should try our best to send every possible culture depending on the source of infection.
Yes.
I think since there are no other questions, I would like really to thank you, Professor Zolt, for this excellent talk and sharing with us your experience. I would like also to convey my gratitude and to the Saudi Society of Clinical Chemistry, Dr. Samia, and the organizer, and for giving us and the audience this great chance to meet you and to listen from you. Thank you so much.
It was a pleasure from my side. Thank you very much, and have a very nice conference.
Thank you very much.
Thank you. Bye-bye.
Bye-bye.